Hi everyone. My name is Joanna. Welcome to this class. Last class we talked about pathophysiology involved in Parkinson's disease. Today we're going to talk about the classical Parkinsonian motor symptoms. We're going to see all motor disorders related to the disease, and talk about how motor problems worsen as the disease progresses, affecting functional independence and quality of life. I hope you enjoy this class. Please, pause the video as many times as you need. As we already have seen, Parkinson's disease is a progressive multi-system neurodegenerative disease. The disease has distinctive neuropathological brain changes. The crucial pathological feature of Parkinson's disease is the loss of dopaminergic neurons in the substantia nigra pars compacta. With the progression of the disease, substantia nigra and other nuclei of the midbrain and forebrain become affected. It is very important to remember that this degeneration starts before the onset of motor symptoms, which means that the loss of dopamine neurons may start very early and before people start to notice the motor signals. The classical motor symptoms of Parkinson's disease have been recognized as prominent components of the disease since James Parkinson's initial description. In most cases, symptoms start in one side of the body, with contralateral symptoms appearing within a few years. But asymmetry persists throughout the disease. The Parkinsonian symptoms include bradykinesia, muscular rigidity, rest tremor, and postural instability. As the disease progresses, these impairments result in problems of gait, balance, and functional mobility. The body posture becomes stooped. There is axial and limb rigidity, tendency for a shuffling gait, and lack of arm swing while walking. Motor disorders also lead to falling, which tend to increase in frequency and severity with the progression of the disease. As we have seen, Parkinson's disease has a set of motor symptoms that are characteristic of the disease. On the other hand, motor features in patients with Parkinson's disease are heterogeneous, which has prompted attempts to classify subtypes of the disease. Two major subtypes were suggested. Tremor-dominant Parkinson's disease, with a relative absence of other motor symptoms. Non-tremor dominant Parkinson's disease, which includes phenotypes described as akinetic rigid syndrome and postural instability gait disorder. Course and prognosis of the disease differ between the subtypes. Tremor-dominant Parkinson's disease is often associated with a slower rate of progression and less functional disability than non-tremor dominant. We have seen some important information in the class about the physiopathology related to Parkinson's disease. Do you remember the motor cortex circuitry involved in Parkinson's disease? Parkinsonism results from a decreased dopaminergic transmission in the motor region of the striatum and increased inhibitory output activity of the basal ganglia. Parkinsonism is associated with changes in these relays. Nigrostriatal dopamine deficiency has opposing effects on the direct and indirect pathways. Now, let's talk more about the motor symptoms. Bradykinesia means slowness of movement. People with Parkinson's disease have difficulty in executing more complex movements, such as repetitive, concurrent, or sequential motor actions. Bradykinesia results from the disruption of neurotransmitters used in the neural projections from the globus pallidus to motor cortical regions as the supplementary motor area in the primary motor cortex. The supplementary motor area is essential in regulating the increase of neural activity that needs to occur before a movement is executed. It also ensures that a movement is terminated at the appropriate time. If the preparation for the forthcoming movement is disrupted, then movements can be reduced in size and speed. Then bradykinesia occurs. People with bradykinesia have trouble in performing repetitive or sequential movements. This is because movement size, progressively decreases during sequential actions. This diminution of movement can be clearly seen in people with gait hypokinesia, in whom the footsteps become shorter and shorter. Also, the amplitudes of handwriting become smaller, a phenomenon called micrographia. The handwriting of people with Parkinson's disease is typically miniaturized and becomes both smaller and slower as a paragraph is written. Slowness may be so marked as to result in deficiency of movement, which is known as hypokinesia. Individuals with hypokinesia typically have an expressionless, mask-like face and walk with reduced trunk rotation, short steps, and diminished arm swing, which is more pronounced on one side than the other. In worst-case scenarios, if there is no activity in the supplementary motor area and primary motor cortex, movement fails to occur. Absence of movement, associated with inability to initiate movement, is known as akinesia. On the other hand, the sudden cessation of movement, motor blocks, partway through an action sequence is known as freezing. Continuing on the motor symptoms, let's talk about muscle rigidity. There is some evidence that rigidity is due to abnormal activation of long-latency stretch reflexes, coupled with an increase in central reflex gain. In addition, muscle stiffness is increased in people with advanced Parkinson's disease due to changes in the peripheral mechanical properties of the muscles. Rigidity can be detected by slow passive movement of the affected body part, while the person focuses his or her attention on a secondary task, such as reciting the days of the week backward. Postural deformities are a frequent complication of Parkinson's disease too. These deformities include abnormally flexed body posture, with flexion originating in the thoracic or lumbar spine, called camptocormia. Forward flexion of the head and neck, called anticollis. And scoliosis, a lateral curve of the spine, usually combined with rotation of the vertebrae. The pathophysiology of these deformities may be multifactorial, and probably includes rigidity, axial dystonia, myopathy, and centrally impaired proprioception. One of the cardinal symptoms of Parkinson's disease is a low-frequency resting tremor that has been linked to dopamine depletion in the globus pallidus. Changes in cerebellar activity and the interaction between the basal ganglia and the cerebellum might be important for the pathophysiology of tremor. Around 80% of patients have limb tremor, most commonly a resting pill-rolling type of tremor of the hands. Pill rolling relates to the tendency of the thumb and the index finger to get into contact and perform a circular movement. Occasionally, the tremor involves the legs. And other types of tremor can occur. Dystonia is another motor symptom in Parkinson's disease. Dystonia is a sustained muscular contraction, frequently accompanied by abnormal movements, postures, or both. Dystonia along with dyskinesia constitutes one of the main motor complications related to chronic pharmacological therapy. The most frequent site for OFF dystonia is the foot. Whereas, in peak dose, dystonia neck and face are more commonly involved. Now let's talk about the postural instability. Postural stability may be affected either early or later in the disease process. The inability to properly balance the center of mass on the support base may lead to falls and injuries. Many factors are attributed to the occurrence of postural instability in Parkinson's disease. These include postural changes, postural reflex loss, inability to integrate visual, vestibular, and proprioceptive inputs, and limited trunk flexibility due to axial stiffness. Balance disorders are also an inherent feature of the disease. The reason why balance is disrupted is unclear. It appears to be associated with neurotransmitter disturbances in the output projections from the internal globus pallidus to the midbrain and brainstem regions, involved in maintaining upright stance and extensor muscle activity. A balance disturbance in a person with Parkinson's disease is most easily detected by pull test. By quickly and unexpectedly pulling the person backwards from the shoulders, while he or she is standing, with his or her feet slightly apart. In people with Parkinson's disease, postural responses are compromised, and the ankle, hip, arm, and stepping strategies are either absent or diminished in amplitude. They might take several steps backward to recover stability. Or, fall rigidly into the therapist's arms. Now, we will learn about gait impairments. The Parkinsonian gait is generally characterized by reductions in stride and step length, as well as by restrictions on the range of motion across all lower limb joints and pelvis, in all movement planes. Gait problems worsen as the disease progresses. This is a major disease burden that markedly affects independence and quality of life. In the early stages of the disease, the gait is slow, step length is short, and interlimb asymmetry is present. We can also note a reduction in the amplitude of arm swing, and the timing of swing duration. The range of motion of the hip, knee, and ankle start to diminish during walking. Changes in posture and range of motion further affect the magnitude of movement. For example, contributing to the reduction of step length. In the mild to moderate stage, the movement becomes more bradykinetic, with disease progression. Arm swing is reduced, bilaterally, with accompanied reduction of axial rotation. Freezing of gait and festination might appear, and patients have an increased risk of falling in this stage. In the advanced stage, the changes in gait worsen. Blocks in motor function become frequent, accompanied by reduced balance and postural control, and severe risk of falling. Other gait problems include blocking and hesitancy. Let's talk about festination. Festination is a tendency to accelerate the gait, with a tendency to move faster and faster, but with smaller and smaller steps. In this case, the center of gravity falls forward over the stepping feet. Freezing of gait is an incapacitating gait symptom that is strongly associated with falls. Freezing of gait is associated with disease severity, although it can be seen early in the course of the disease. Its pathophysiology is complex, probably involving multiple regions of the cerebellum and brainstem, responsible for locomotion. But the neurobiological mechanisms are still poorly understood. Freezing of gait is clinically characterized by sudden, fairly brief episodes of inability to produce effective forward stepping. These episodes typically occur during gait initiation or turning while walking. In summary, in this class we discussed Parkinsonian motor symptoms include bradykinesia, muscular rigidity, rest tremor and postural instability. Motor symptoms may result in problems of gait, balance, and functional mobility. Course and prognosis differ between the subtypes of the disease. The Parkinsonian gait is generally characterized by reductions in stride and step length, as well as by restrictions on the range of motion. Other gait disturbances than shuffling include blocking, hesitancy, and gait festination. More than half of the patients have freezing of movements. Thank you for watching. Remember to do the quiz. It will help you memorize this content. Next class, we will talk about non-motor symptoms. See you.